Physiology and Mechanical Ventilation. I'm Nahal Saeed, Associate Professor of Anesthesiology and Critical Care at Vanderbilt University. Quick reminder of basic physiology. Our inspiration is an active process where we store energy in the elastic recoil of the lung, followed by expiration, which is a passive process, and that's why it takes longer. Usually I to E ratio is 1 to 2 or 1 to 3 in normal breathing subjects. Also, minute ventilation is about the respiratory rate times tidal volume. We breathe about 500 cc tidal volume each breath at resting state. Multiply that by 10 breaths per minute on average, you end up with 5 liters of minute ventilation. The FRC, or functional residual capacity, is lung volume that is comprised of expiratory reserve volume and residual volume. It is about 2.5 liters in an average adult, and it's where gas exchange happen. We breathe in and out to change the constitution of the FRC gas mixture, and the FRC gas mixture will in turn get in contact with the blood flowing in the pulmonary capillaries and change its constitution, giving it oxygen and taking back carbon dioxide. The FRC as a volume is increased when there is patients with obstructive lung disease like emphysema, or decreased in restrictive lung disease, similar in pleural effusions and restrictive lung disease due to pulmonary fibrosis, for example. It's easy to remember the importance of FRC by recognizing how long the patient can remain apneic without perceived hypoxia. If you fill the FRC, which is 2.5 liter, with 100% oxygen by what we call denitrogenation or pre-oxygenation in some terms, then you have 2.5 liters of oxygen that can be provided to the pulmonary capillaries without having to have actual breathing at this time. We call apneic oxygenation, and in this case the FRC will provide the oxygen for extended period of time, 5 even 10 minutes in some cases, without the patient having to take a breath. It's helpful when you're preparing to control airway by intubation and in similar conditions. I'll also remind you that dead space, anatomical dead space, is where gases passes in and out but no gas exchange happen, and this is basically the tracheobronchial tree in addition to the oronasopharynx. It's about 150 ml, so it's in tidal breathing would be about 30% of the tidal breathing. That means if you multiply that by the respiratory rate, you end up with 1.5 liter of gas that is dead space ventilation out of the 5 liters minute ventilation that we usually breathe at rest. Why this is important is because I want to show you when the patient is breathing shallow, faster. So in this example here, patient is still having a minute ventilation of 5 liters, but instead of a tidal volume of 500, he's breathing half that, 250, and breathing twice as fast, so that's from 10 to 20. That will still give you 5 liter minute ventilation, but you actually doubled your dead space because anatomical dead space is fixed. So 150 mLs of dead space, anatomical dead space times 20 respiratory rate, that will give you 3 liters. So that means the dead space here is 60% of minute ventilation. Very ineffective way of breathing. You have your work of breathing is higher, but your breathing is ineffective because most of it is in dead space, and alveolar ventilation is only 40% of your effort. Now compare that to a very slow patient. For example, would be a patient who received a large dose of narcotics. They are hypoventilating. Their tidal volume become larger. So they will breathe a liter of tidal volume, but they breathe slower, which is 5 per minute instead of 10. You see that the dead space has been reduced to 0.75 liters, less than 1 liter out of the 5 liters minute ventilation, and hence the dead space is 15% only, and that would be very effective way of breathing. So alveolar ventilation become a lot more than if you're going at the normal rate. A quick reminder of shunt. Shunt is the difference between oxygen concentration in the alveoli and oxygen concentration in arterial blood. That's how we measure it. But shunt means that blood that passes through the lung without having gas exchange happen in it. And before we go there, we will remind you that there is an oxygen tension cascade from the all the way up to the atmospheric 21% FiO2. Oxygen will start going to the alveoli, and that would give you alveolar oxygen concentration of about 100 PaO2 millimeter mercury, and then that will have a physiologic shunt that will cause that to drop to the arterial side a little bit, so to 80 millimeter mercury, and then going all the way through the capillary to the interstitial fluid and the cytosol, and then to the mitochondria, which is the target of oxygen molecule. You end up with very low concentration of PaO2. The PaO2 is about 10 to 12 millimeter mercury at the mitochondrial level. So big changes can happen in the upstream. It can be reflected very severely in downstream as well. Here is a dreaded concept, west lung zones. I'm going to try to simplify it as much for the purpose of this lecture. And it's actually not very difficult to understand as long as you remove the extra padding of the concepts. So the lung is like a water balloon. If you imagine the lung as a water balloon and you hold the water balloon from the top, it sags down. But that doesn't happen in the lung because the lung is actually surrounded by the chest wall, and the chest wall keeps a shape, so it will not allow the lung to do that, and hence the lung would be pulled up from the pleural space to the chest wall, and so it will not be saggy like a water balloon. So basically the lung is suspended in the thoracic cage. By doing so, you're pulling a lot more on the upper part of the lung and much less on the lower part of the lung if it was to be allowed to become a water balloon. And by doing that, you expand the alveoli in the apex. So zone 1, where it's the top of the lung, if you're sitting or standing, would be having the most tension from the pleural space, and hence the alveoli is over-distended, full of air. So it's over-distended alveoli, but it's not ventilated, meaning that because during inspiration and expiration, this alveoli is full of gas all the time. So actually it's not ventilated, but it's over-distended with gas. When you over-distend the alveoli with gas, it compresses on the capillary under it, and hence the pressure on the alveoli in this case would be higher than the arterial side, which is about 25 millimeter of mercury. That's the systolic blood pressure of the PA, minus the column of blood and the gravity from the level of the heart to the apex of the lung, and hence it's very low pressure. Alveoli is over-distending, compressing the capillary, and the venous side is actually compressed as well. So there is no blood flow to the apex of the lung, and there is no ventilation. There is over-distension, there's a lot of air, but it doesn't move in and out. And hence it's matched. The VQ matching, ventilation perfusion, is matched. You go to second lung zone, whereas the arterial pressures become higher than the alveolar pressure. So there is some flow during inspiration and expiration. And the venous side is a little bit engorged, but at the level of the heart, so there is still sometimes closing and opening. So there is basically intermittent perfusion during the second part of the lung zone. But look at the third lung zone, the base of the lung. The base actually has a highest pulmonary artery pressure because it's the 25 millimeter mercury plus the gravity effect on the blood below the heart. In addition to that, the alveoli is on the bottom of the lung and it's compressed, and the diaphragm moves here very significantly. So this alveoli actually completely collapse and completely open every time the patient take a breath and exhales. At the same time, the venous side has to go upstream against gravity to the level of the heart, and hence the venous side is open all the time. So there is the maximum perfusion, as you can see. The artery is higher pressure and the venous is all open. And at the same time, the alveolar pressure is the lowest and it's collapsible. So the most ventilation happen at the basis of the lung, and the most perfusion happen at the basis of the lung. So there is again a very good ventilation perfusion matching. How does that translate to compliance of the lung? If you look at the zones again, if we draw volume pressure changes, very small amount of pressure changes, 5 centimeter of water, for example, will cause about 500 cc of volume change in the lung. Why? Because the base of the lung is very compressible. The alveoli collapses and opens again and gets full of air. Hence, it is compliant lung. Now you go further up to the second lung zone, and the compliance start to take a hit. For the same amount of 5 centimeter of water, you get much less tidal volume and even less in the apex of the lung. You can see here very little changes, and maybe the 5 centimeter will cause maybe 50 to 100 cc of changes versus 500 in zone 3. Now, in general, those zones will change according to gravity and position. So if you're lying flat, the anterior part of the lung will be zone 1, and the posterior part of the lung or your back will be zone 3. Quick reminder on what is AA gradient, alveolar arterial oxygen tension gradient. Not all the blood that goes to the alveoli will get oxygenated fully and come back. The reason for that is there is a shunt, and the shunt will be either a non-functional alveoli somewhere else, or the blood will find a way from going from the arterial side of the pulmonary circulation to the venous side without passing through the interface between it and the alveoli, and hence there is no oxygenation. So let's see what is the normal difference of between partial pressure of oxygen in the alveoli and in the capillaries. I'm gonna make that step by step. So let's first calculate the alveolar PaO2. How do we do that? So first of all, let's find out what is the partial pressure of oxygen. So partial pressure of any gas is its percent mixture and in the total pressure of the gas comprised. At sea level, barometric pressure would be 760, and the FiO2 in normal is 21%, so 0.21, and that would be the PaO2. But remember, there's two differences, major differences in the alveoli. The alveoli are fully saturated with water vapor. By the time the air goes all the way through the bronchial tree, it gets fully saturated with water vapor. So we need to subtract the partial pressure of water vapor from what we usually breathe in. So that would be 760 barometric pressure minus 47. That's the partial pressure of water vapor as 100% saturated, and multiply that by 0.25, which is the FiO2. You end up with 150. But one more factor there. The alveoli are semi-closed space, and blood is flowing under those alveoli, bringing carbon dioxide all the time. So carbon dioxide is diffusing into the alveoli, changing the mixture as well. So to have to factor this out, we're gonna get 150 millimeter mercury minus PaCO2, which is around 40 in average, and divided by the respiratory quotient, and you hence it up with 100 millimeter mercury. So the alveolar oxygen tension is 100 millimeter mercury. Now we know what is the partial pressure of oxygen in the alveoli. Now we go send a blood gas and measure the arterial partial pressure of oxygen, PaO2, P small aO2, and we can subtract the amount difference, and that will give you the AA gradient. So PaO2 we calculated was 100. Usually when you run a blood gas on a normal healthy lung, you will have a PaO2 of 80. It varies with age. It starts higher than that a little bit at young age, and then with age all the way to 70 and 80, your PaO2 expected to be in the 65-70 range. But given that middle-aged person will have 80, then there is a normal AA gradient of 20 millimeter mercury. Where did that difference come from? It's come because physiologic shunts. Physiologic shunts are venous blood that is crosses without going through the alveoli, and that would be the bronchial circulation. Bronchial veins drain directly into the left side of the heart, coronary Sebastian drainage, left ventricle cavity, there is some blood that will draw back into the left ventricular cavity straight versus going to the coronary sinus. And also there is a very small amount of lung that might not be ventilated every time you take a breath, and that will contribute to the small difference. Now we got some of the physiological concepts reviewed. Let's go and talk about mechanical ventilation. I'm going to talk about conventional mechanical ventilation. We will call it positive pressure ventilation. There is non-conventional, I'm going to touch on at the end as well. We're going to talk about physiologic effect of positive pressure ventilation, what ventilator strategies we should use for each patient, and what complication can arise from positive pressure ventilation. So mechanical ventilation started by the iron lung. And if you remember the iron lung was a big tube you put the patient in, the head is outside, you change the pressure into that tube by a motor that will compress gas in and out. You press on the chest wall since the head is outside the tube, which is atmospheric. If you increase the pressure in the tube, it becomes higher, patient exhales. If you decrease the pressure in the tube, patient take a breath. This is very physiological because your pleural pressures are like normally when you're taking a breath, an aspiration is a negative process, meaning that you increase the negative intrapleural pressure, the chest expands, and hence the lung follow it and take a breath from the atmosphere. And when you exhale, the reverse of that happens. The chest wall collapses, pressing on the lung and increasing the pleural pressure to positive, and then you exhale air out. So iron lung was very successful in the 50s and the 40s, where there was a polio epidemic. Polio epidemic patients had normal lung compliance, but they have very strong weakness, and the weakness will not allow them to breathe. So you put them on those tubes or iron lungs for a week or two, and you end up getting better on the muscle weakness of respiratory muscles, and hence they improve when you take them out. Now, iron lung, as physiologic as it is, it's not very good if you have patients with severe decreased lung compliance, because the change, and as well as taking care of patients in such a setting is very difficult. Imagine putting an IV, cleaning them up, and so forth. It become a nightmare. So by inventing the endotracheal tube, it's a tube you put into the trachea and you secure that trachea, then we can actually pressurize the systems through that tube. And we invented, or we started using positive pressure ventilation. Now, there is only two modes of respiration that exist all over the world. They either volume modes or pressure modes. I'm going to talk about volume mode here. And volume mode in the ICU is basically what we call flow limited volume cycle. What is flow limited volume cycle means? ICU ventilator do not have a displacement mechanism for air. Basically, there is no bellows inside them. What's happening is there is a continuous airflow through those ventilators, somewhere between 20 liters per minute all the way to 60 or 70 liters per minute. If you close the valve, the air will go to the patient. So if you, let's say you have a flow of 30 liters per minute, that means that you have a flow of half a liter per second, because you have 60 seconds, 30 divided by 60. So if you close the valve for 1 second, that's what we call at a flow of 30, that means you will have 500 cc go to the patient. And so that we call it flow limited, because the limit here is 30 liters per minute, and we cycle it on volume. As we deliver the volume we set, we open the valve and let the gas just pass by the patient. So if the flow rates were 60 liters per minute instead of 30, that means you have 1 liter for every second. So if you want a total volume of 500, you have to close the valve only half a second for each breath to deliver the 500, and so on and so forth. Now, as every other mode, if you're gonna decide on volume, you want to make sure you measure pressures. The second mode of ventilation, which is pressure mode, instead of asking the ventilator to deliver a set tidal volume or volume, you're going to ask the ventilator to change the airway pressure from X to Y, meaning that it's pressure limited time cycle. So in this case, I'm going to say I'm going to pressurize the airway from amount of 5 centimeter of water all the way to 20 centimeter of water for time cycle, 2 seconds, and then I'm going to drop it back to 5 centimeter of water. In this case, the cycle will repeat, so on and so off. So basically, I'm going to set pressure, that's 20. I'm going to set time, that's 2 seconds, and I'm going to set the ventilator, and that's called pressure mode. And since we are setting pressure, we want to measure volumes, because eventually we want to know how much minute ventilation the patient is getting. Now, any positive pressure ventilation is a cycle, and the cycle will be on for a certain amount of time, off, rest, and repeat. So basically, every single mode of ventilation I'm going to explain to you right now is in those understanding. So you're going to have to see how the cycle is designed and how often it is repeated. Now, there is now trigger mechanism that we added to the mechanical ventilators that will interact with the patient. I'm going to show you those as well. And then we're going to see either flow limited volume cycle, that's volume modes, or pressure limited time cycle, and those are the pressure modes. Let's look at the anatomy of any ICU ventilator. Any ICU ventilator will start with oxygen source and air pressurized, medical usually. You blend those together with a blender, and that blender sometimes is outside the ventilator or inside the ventilator. And you take that mixture according to your FI2 that you want, 50% say, and you put those through a valving system. So the ventilator is basically a valving system. You take that air from the valving system and put it in a circuit, flexible circuit, to take to the patient. It's called the Y circuit. And this Y circuit will have an expiratory valve that will be controlled by the valving system. And this is very basic system. But for you to control things in the valving system, you have to control the flows. So that was 30 liters per minute, 50 liters per minute flow. You have a continuous flow controller. And you also have a positive pressure breast. That's we're going to tell you how many rates. So you're going to close the valve and open it 10 times a minute or 20 times a minute. So that would be the positive pressure breast controller. And that will control the expiratory valve and the inspiratory valve. Now, and to control those two, you cannot directly control them unless you have knobs. And so that's the knobs they put on the front of the ventilator. Now it's touch screen and other things. But the idea here is to set the mode, to set how those pressure breaths will be set and how the continuous flow control will be set. You need the mode controllers. And the mode controller also will modify the behavior of the expiratory valve control. Now, until this point, there is no interaction between the vent and the patient. If you set 10 per minute and continuous flow 30, then this is what's going to happen. If the patient wants to take a breath, wants to cough, the machine will not respond to him. Until we put something called demand sensor. Demand sensor basically is sensors to measure the differential flow between the inspiratory and expiratory valve. And if the air is not exactly and the inspiratory is equal to the expiratory, that means that the patient is deciding to take some breaths or there's some air going somewhere else. And hence the machine will learn that the patient is taking a breath. Now what the machine do with that breath depend on the mode you're going to set. So the demand sensor is always on, but it's not effective unless the mode you choose will have the demand sensor control through a circuit the positive pressure breath controller and decide on how to help the patient during this period. Remember that we have a very dry medical air coming all through. If you leave that at a high flow, if you leave that to the patient all the time, patients will dry out. There is no humidification. So hence we put something to humidify the inspiratory air. This is either a boiler that you see sometimes. You boil air, you boil water, and water vapor will saturate your medical gas, or you put an HME at the Y area. HME is heat moist exchanger, which keep the moisture on one side and hence the heat as well with it, and hence the patient will keep his own moisture and will not dry out. So for positive pressure ventilation, we either control volume and hence we'll monitor pressures. And if we control pressure, we will monitor volumes. And for assisted or interactive modes, which also lie in both pressure or volume assist, we're going to monitor the opposite. So here's the effect of positive pressure ventilation on respiratory mechanics and hemodynamics. So for respiratory mechanics, one thing you want to remember is that if you want to manipulate the carbon dioxide elimination and hence PaCO2, you want to improve or increase alveolar ventilation. And alveolar ventilation is basically minute ventilation plus dead space. So if the dead space is unchangeable, then you're going to have to increase minute ventilation to get to the same amount of alveolar ventilation. On the other hand, if you want to modify PaO2, you want to modify shunt that by recruiting units. We're going to talk about that next. And that would be with techniques like PEEP and inverse ratio ventilation, and also FiO2. So for PaO2, you want to modify FiO2 and shunt, and for PaCO2, you want to modify dead space and minute ventilation. Remember, everything is inverted while you're doing positive pressure ventilation, because the thoracic pressure is positive during inspiration and negative during expiration, or lower during expiration, compared to normal breathing, which is negative during inspiration and positive during expiration. So things that will be affected is CVP reading, wedge pressure reading, venous return, and hence cardiac output as well. This is just to remind you that dead space can affect carbon dioxide elimination, and the larger the dead space, the more minute ventilation you will need to obtain the same PaCO2. So for example, if you have a patient and you want the PaCO2 to be at 40, which is normal, and they have a dead space of 20%, that will require about 4 liters of minute ventilation. That's what usually normal is. Now, if the patient had 70% dead space, then you'll end up requiring 8 liters minute ventilation to obtain the 40. And even if they have 80% dead space, they will require around 12 liter minute ventilation. By doing that, if you check the amount of minute ventilation the patient is requiring to obtain normal PaCO2, you can predict percentage dead space present. A few more concepts about positive end expiratory pressure and CPAP, continuous airway pressure. Here's a PEEP, or positive end expiratory pressure. The idea is that there is units in the lung, and units are the alveoli, that is collapsing and at the end of expiration. And when they collapse due to deficiency of surfactant or increased alveolar fluid, those walls will stick together because of the surface tension of the fluid in them. Now, to open those again, you need a higher positive pressure to open them. And if you're using average pressure, some of those units might not open again because you did not reach the critical opening pressure for them. And hence the idea of PEEP. In PEEP, instead of going all the way down to 0 centimeter water pressure at the end of expiration, you raise the end of expiration to 5, 10, 15, depending on how many units and how much pressure need to keep those sticky or collapsing alveoli open, stent open, as in the last couple of pictures. So at the end of expiration, instead of the walls of the alveoli sticking together and the surface tension has to be broken to be opened again, they remain stented open, and hence they can open in the next cycle with less pressure and easier. So those are units that you recruited, and when you recruit units that are not opening before, which were shunt, that means you are decreasing the shunt and hence improving oxygenation. This is an important curve for mechanics of respiration, and this is called pressure volume curve. And the pressure volume curve is we're drafting the pressure on the x-axis and volume on the y-axis. And we do that statically, meaning that we inject air in the lung and we measure pressures, if 100 cc at a time, for example, and we measure pressures. And you can see here that the curve is formed S-shape looking. The expiratory curve is in the light blue, is a little bit different due to the different mechanics. But let's focus on the inspiratory green curve. This curve actually have an inflection point we call the lower inflection point. And this lower inflection point is telling you where the alveoli were collapsing and opening every time. So if those alveoli here, when they are collapsed, they are less compliant, and hence you need higher pressure to create the same amount of volume, and hence the compliance curve is bad. Now, after you open all or recruit all those alveoli, you see that the curve kind of stands up and become better until it worsens again at the end. And the upper point of inflection to change the direction of the curve, we call it upper inflection point. And this is where you're over-distending the alveoli. So if the alveoli of all of them are full of air and you add more air to them by adding pressure, that will over-distend them against their elastic recoil, and hence you might be destroying their elements as well. So this is we call the over-distension zone. So basically what you're trying to do is trying to keep your PEEP or CPAP above the lower inflection point. So let's say the lower inflection point here is 6. I want the PEEP to be 7, and hence the alveoli will stay open all the time. So I will stay ventilating between those 2 points, the lower inflection and the upper inflection. And you want your plateau pressure or alveolar pressure to be less than the upper inflection point, and hence you do not over distend the alveoli. This is a very old study done in 1976 where Webb and Tyranny demonstrated a very interesting concept, the protective effect of PEEP. So what they did is they got animals and they ventilated them with different pressures and then they for hours, and then they cut their lungs and weighed on the scale. Now if the lung is injured and inflamed, then the lung will collect more water and it will weigh heavy on the scale. So the first animal were ventilated with 0.15 and that lung was weighed on the scale and looked something like that. And then they did 0.45 and hence the lung was full of water and way heavier. And they said, okay, we'll add PEEP to this. So instead of 0 to 45, 10 to 45. And that usually gives you more blood pressure. If you think, more airway pressure. And hence should mean airway pressure will be higher. So would that be more destructive? And they found the opposite. They found that the lung that was PEEP added to did not weigh as much as the lung that did not have PEEP, despite that the mean airway pressure in this lung is way higher. And hence the protective effect of PEEP was recognized. So, and the reason for that is when 0 to 45, you're opening and collapsing alveoli, and the sheer opening and closing of those alveoli destroy their elements and hence cause more inflammation. But if you add PEEP, your excursion between 10 and 45 is less than the excursion between 0 and 45, and hence less destruction and less inflammation, and you protect the lung. So that's why we use PEEP to recruit alveolar units and decrease shunt, as well as protect the lung from destruction. This is just to remind you that your mechanical ventilation will optimally be between the lower inflection point and the upper inflection point. PEEP above lower inflection, plateau below upper inflection. So what are the ventilator strategies that you should have? I mean, the question that you usually get asked every time by a nurse is, doctor, what vent setting would you like for your patient? And the answer is, what do I want to achieve with vent setting? So the first thing is, for total support, you want the patient to be oxygenated. And this is at any given price. The patient need to have a saturation of 90% or better. And that is paramount, because without that, patient will die. Now, so you do everything you can to do that. And you use a higher FiO2, you use higher pressures, you use higher volumes, you use everything to get the saturation to 90. After you achieve that, you want your FiO2 to be reduced to 60 or lower, because oxygen toxicity is recognized for 6 hours or more than 60%. You have superoxide radicals, you have cilia destruction, and you have difficulty clearing secretion for patients who are intubated, and so forth. So you would like to reduce FiO2. And also, we know from the studies done earlier that if you use plateau pressure more than 35 centimeter water, and some people would like to use 30 centimeter water, then you're destroying normal lung elements, and hence you are shooting yourself in the foot, because if you have inhomogeneous disease like ARDS, and you have some lung that is normal, some lung that is diseased, you're actually having the pressure destroy the normal lung if you go above 30 centimeter water. So you want to reduce your plateau pressure as much as you can, and then you want to make sure that CO2 is normal. So, but remember, this is important in order, meaning that you cannot sacrifice the first point so you can achieve the second point. You cannot say I will increase the plateau pressure so I can get ventilation and normal CO2. No, that's not acceptable. You can accept actually hypercarbia and respiratory acidosis in patients as long as if you would to achieve normal carbia, you would have to raise your pressures or volumes, and then eventually decrease the work of breathing. Some patients will need to, unable to provide support for work of breathing, which can be up to 40-50% of basal metabolic rate in severe respiratory distress. So if you have a patient who's congestive heart failure, for example, and his cardiac output is barely adequate, if you take the work of breathing away, you might have adequate cardiac output in this case, because the work of breathing is eliminated. Now, some people will say, I can tolerate higher FiO2 if I can reduce alveolar pressure quickly. And the idea here is that the belief is that higher airway pressures are more injurious to the lung than higher FiO2 for the same amount of time, and hence that would be acceptable as well. But the order is oxygenation, plateau pressure is below 30, 35, FiO2 below 60, then look at the CO2 if you can get it down, and then decrease work of breathing. So as you proceed with strategy to ventilate your patient, if you are worried about oxygenation, then you're going to have to adjust the FiO2 to get the oxygen saturation 90% or better. You also would like to reduce shunt by recruitment, and that would be by positive end expiratory pressure, PEEP. And you want to do that so you will recruit the unit but not over distend alveoli. There is a unscientific term called permissive hypoxia. Permissive hypoxia means that you don't have to have your patient saturation 100%, just 90% or better is adequate. That's not hypoxia, but it is not the magic number that we all look for. And then long I time. Long I time will happen only if you use shorter E time. So the I to E ratio will be inverted, or even 1-to-1, and then inverted 2-to-1, and even more, depending on the situation. That will also help oxygenation. Now, if you are concerned about carbon dioxide elimination, the first thing you need to think about is permissive hypercarbia never harm patients. So if reducing CO2 by increasing minute ventilation, or increasing tidal volume, or increasing pressures will result in normal carbia, don't do it, because as long as a patient had a pH of 7.15 or better, it will not have any harmful effect from CO2 even in the 60s to 80s. So go ahead, allow patients to have carbon dioxide high enough, as long as their pH is staying between 7 0.5 or 7.2 or above. Now, if you can achieve normal carb without having to sacrifice increasing pressures or increasing tidal volume, then you can achieve that. However, it's not mandatory. So let's start by assist control ventilation. Um, there is controlled ventilation, but it's very hard to find such ventilator in the modern era. So assist control is probably the starting mode that you will think of uh, nowadays in the ICU. So it's a full control mode. It will deliver a set tidal volume, usually start by 6 ml per kg. You can go up or lower, although we tend to use lower tidal volume as a protective strategy. We set also a respiratory rate somewhere between 8 and 20, depending on the tidal volume chosen. You might increase the rate to compensate for the decreased tidal volume. But in addition to the delivered set rate and tidal volume, if the patient triggers the vent in assist control mode, he will get the full support of the same tidal volume. So if you set the vent at 10, for example, and the patient triggers 2 extra breaths, the tidal volume will be delivered exactly the same for the 2 extra breaths in addition to the 10. So basically in assist control you set tidal volume and respiratory rate, and the ITE ratio will depend on the flow. Now a modern ventilator will compute how much flow liters per minute it will require to deliver the tidal volume in the set time, so the ITE ratio will stay where you want it. So most of the new ventilators will set ITE ratio directly, but if you have an older version that does not do that, you're going to have to adjust the continuous flow to get your ITE ratio to the desired effect, usually 1 to 2, 1 to 3. And since you're setting tidal volume, you have to monitor airway pressure so you prevent barotrauma. Now, to understand how ventilators work and how they interact with the patient, I'd like to show you what happened on 3 major factors: the pressure of the circuit, the volume delivered to the patient, and the flow characteristic during each breath. So we're talking about assist control, AC. We're going to set it up 500 ml tidal volume, respiratory rate of 10, and PEEP of 5, and FiO2 would be 50%. So the machine will close the valve depending on the flows for a certain amount of time to deliver the set tidal volume, which is 500 ml. If the flow rates are 30 liters per minute, then to deliver 500 you need 1 second. So the machine will close the valve for 1 second. And you can see that when you close the valve, the pressure will rise, the volume will go to the lung of the patient. And then when the 1 second is finished, open the valve and drop. The flow characteristic reverses and the patient exhales back to base lung volumes. And I keep repeating that. And also if the patient trigger, which is indicated here by the dimple and the pressure red curve, then the patient will get the same 1 second of valve closure, delivering 500 to the patient and with the same flow characteristic. So despite that the set rate might be 10 breaths per minute, the actual rate might be higher. So since we set up the tidal volume, we're going to go ahead and look at the pressure and set our alarm or monitor to monitor for harmful pressures, and that would be above 30, 35. Now pressure control ventilation is very similar, but instead of we setting volume, we're going to set a pressure. So in this case, we're going to set a pressure of 20 centimeter of water above PEEP at 12 rate, but because this is time cycled mode, pressure mode is time cycled mode, so we're going to set an inspiratory time of 2 seconds. By doing that, we set up the IT ratio indirectly, if you notice. So if we have 12 breaths per minute, that means that each cycle, respiratory cycle, will be 5 seconds. If we take 2 seconds in inspiration, then what's left is 3 seconds expiration. So that would be a ratio between 2 to 3 IT ratio. Now, PEEP of 5 and then FiO2 of 50%. So let's see how that works on the curve. So the CPAP is 5 or the PEEP is 5, and then we're going to raise the pressure to 20 above that for the duration of 2 seconds, and then the patient will, because of the airway pressure rises, the volume will, or the flow will flow to the lung, and the volume will get to the patient, and the volume will be dependent on compliance. So if you have a very stiff lung with a pressure of 20, you get a smaller tidal volume. If you have a very compliant lung, you can get a liter and a half of tidal volume for the same pressure. And the same thing, because it's now there's no pure pressure control, it's what we call it assist pressure control. So if the patient triggers, he gets also the same pressure support for the same duration. And since we set up pressures, we need to make sure we monitor tidal volume, because if the tidal volume changes due to the compliance, we need to know about it to adjust our setting. Now, to avoid the idea that the ventilator will support the patient with every breath, only we want the ventilator to deliver, say, the sit rate at the sit tidal volume, but not more. So if the patient triggers, in addition, patient does not get support. We call it intermittent mandatory ventilation. An intermittent mandatory ventilation means that it's the same volume mode. We're going to set it at 500 ml, say 10 per minute, PEEP of 5 and FiO2 50%. And here we go. We go to deliver the 500 ml depending on the flow characteristics. And then if the patient try to take a breath here, the patient is or her on, meaning that you will not get support if that vent is triggered outside of the 10 breaths that are supposed to be delivered. Now, you can have a lot of things here happening also, because since the machine gives a breath every 6 seconds, the cycle is 6 seconds here, then if you are taking a breath and the machine it is time to give another breath, the machine will deliver that breath on top of the previous one. So you can do breath stacking a little bit in intermittent mandatory ventilation. And at the same time, the characteristic of the breath that is taking without support is totally dependent on the patient effort. Now, with the advances of microprocessors, and we have many of those over the years, now we can put small computers inside those machines and have them interact with the patient. Now, the first thing we're going to use this computer for is to synchronize breathing. And synchronized breathing is interesting. So it's we remember IMV, or intermittent mandatory ventilation. We had it before. Ignored the breath at all, and it delivered a breath every 6 seconds in that example. But if we synchronize the breath, because we all don't breathe exactly at the same interval every time. We sometimes take the breath a little bit early, a little bit late. So that was to create a breath that is a little bit similar to normal breathing. So in this case, the machine will create a window. And the window would be usually 30% around the subjected breath. So if this breath is expected to be here on every 6 seconds, I can wait for the patient to trigger. If the patient trigger earlier, within 15% of the time it's supposed to be the breath delivered, the machine will count that toward the breathing and support the patient toward it. Or if it doesn't happen and the patient time is come to get a breath, but he did not trigger, it will wait for a little bit as well, 15% above the time determined, and deliver the breath if he doesn't take it, or if he take it, it will count it toward. So that means that the patient now have control over spacing of the breath within a certain window. Certain window mean within 30% of the timing that the breath was supposed to be delivered. Remember that the breath that is outside the window remains totally unsupported. Now let's go to a pressure support mode. This is not a control mode. So pressure support mode is a very lovely mode that the patient loves so much, especially the awake ones. Why is that? In pressure support, we do not set rate, we do not set tidal volume. We only wait for the patient to trigger the vent and support him with extra pressure until he decides not to take a breath anymore and let him exhale. Now, I will show you how this happened, and then I will show you why patient likes it so much. So the patient, as indicated here, is triggering the vent by taking some air. Now the machine will increase the pressure from 5 CPAP, which is continuous airway pressure, to 10 above that, and it will continue to monitor the flows on the blue curve. The flows will peak, and early on the patient will take a large breath, and hence the flows will be fast. But then when the lungs start to fill up with air, the flows to the lung will decrease despite that the pressure is still the same. And when that happened, the machine will mark the peak of the flows that happened and will wait for 25% drop, and that's modifiable in many of ventilators. And then when the 25% drop from the peak happened, that means that the lung is almost full of air and the patient had enough breath. And hence the patient will be allowed to exhale by dropping the pressure back down to the baseline, and the patient will allow to exhale. Now in the second breath here, if the patient doesn't want to take bigger breath, you can see here smaller, shorter breath, lower flows, but because the drop from peak to 25%, it doesn't matter which peak it is. Every breath determines its peak and drop. And here is you get a breath again. So why patients like this so much is because now they have control over when to start breathing, when to finish breathing, how much effort they want. They can put as much effort as they want or as little effort as they want. And they are not forced to take any tidal volumes that they don't want. So breaths are unequal in many of those breaths. But remember that the work of breathing during pressure support is maximal for the patient. For the patients to continue to take flow to his lung, the patient has to make space for it. Otherwise, the flows will drop 25% if he doesn't expand his chest, and hence the breath will be terminated. The second is that the patient has to have a normal respiratory drive. You cannot have a patient who's apneic to do pressure support. And usually if you set a pressure support, there is a backup mode on the ventilator saying that if the patient is apneic for a certain amount of time, 20 seconds, 40 seconds, then the patient will force the machine to switch from pressure support to another control mode because the patient is not breathing. Now, can you combine pressure support with other mode? Yes, and the answer is yes. Remember that breath in the middle that was outside of the synchronized window in SIMV? Now we can add pressure support, so now we can call it SIMV plus pressure support, and that's probably a most popular mode of ventilation we do in our ICUs. And here it is. Now the pressure, the 10 breaths per minute would be fully supported, and they will move within the 30% window with the patient. But the additional breath in the middle outside the window will get the pressure support that it indicates, as you can see here compared to previously. One more mode that is getting popular and we use it a lot now, it's called PRVC, pressure regulated volume control. Pressure regulated volume control is, I would call it, the lazy caregiver mode. Although it's not just because of that, but it's very simple. So we want to set a tidal volume, but to give that tidal volume, we're going to ask the machine to vary pressures depending on patient effort and lung compliance to deliver that set tidal volume. So the first thing when you say, I'm going to set a tidal volume of 500, the machine will give a test breath. The test breath will be with a pressure of 20, say, over 1.5 seconds. Now, when you give that, the machine will measure the return tidal volume from the patient and compare that to the set tidal volume. If it is less than the set tidal volume, then the machine will increase the pressure. So the next time it will give the pressure, going to give a pressure of 25 for a longer period of time. And then compare that set tidal volume for the return tidal volume. And if it's the same as set tidal volume, it will keep the pressure as it is. If it's less then it will increase the pressure again within limits. And if it's more, if the tidal volume now is 650 instead of 500, the machine will lower the blood pressure and let the patient do more work. So basically the machine every third breath is averaging comparing the tidal volume and the return tidal volume, and if they are different, the machine will go ahead and adjust the pressure to deliver that set tidal volume. That is good for patients because when the patient is awake and strong enough to work on his breathing or her breathing, she can get the least amount of support while guaranteeing she get the same tidal volume. But if the patient is getting tired, if the patient is getting some sedation, if the patient is having a procedure, and the patient is unable to participate in breathing so much, the machine will increase the level of support to give the set tidal volume as well. So you don't have to keep readjusting it. And this is just the same graphic calculation. You see the first curve here, the volume is exactly at the set tidal volume. The second breath here, the tidal volume is bigger than the set tidal volume, so the machine drops the pressure. When it drops the pressure, the tidal volume is less, and it will increase again until it reaches a sweet spot. What are the complications of positive pressure ventilation? Well, artificial airway. Artificial airway is endotracheal tube is a conduit for infection. So nosocomial pneumonias or ventilator-associated pneumonia (VAPs) are not a simple problem in the ICUs, and it increases mortality by 20 to 30%. So being in ICU by itself is high mortality, and adding that much mortality to it is serious. So prevention of infection is very important. There's many ventilator bundles that will decrease the incidence of infection, VAPs. But the best measure to decrease that is to extubate the patient as soon as you can. Mechanical malfunction, almost unheard of. Most of the new ventilators has very sophisticated mechanics and electronics that usually does not fail. And if it fails, it alarms you and tells you what is the problem. It's most of the time it's operator error more than mechanical or electrical malfunction in the ventilator. Patient ventilator dysynchrony, another problem. I mean, the patient is bucking the vent, or the vent is not delivering the tidal volume that's supposed to be delivered, or so on. And in this case, the patient is not relaxed enough to follow the ventilator, or the ventilator is not set to follow an awake patient. And hence, you have two options here: either to sedate the patient and control their ventilation yourself, or have the patient, if they are interactive and ready for weaning, then they can you can choose a mode like pressure support or SIMV to allow the patient some freedom in breathing, and then let them breathe without sedation. Now, air trapping can happen, especially in volume modes. As I told you, IMV, you can have breath stacking. Or because if you're delivering enough pressures and enough volumes but not allowing E-time enough, so instead of delivering the breath after the full previous breath was exhaled, you can stack breaths on top of each other. Oxygen toxicity, you can deliver 100% with endotracheal tube. You cannot deliver 100% with most conventional masks. So 100% for a longer period of time is harmful, as you all know. Now, because also it's a pressured system, tube is sealed, you can cause barotrauma, causing pneumothorax, pneumomediastinum, and all the complication that could follow. And then increasing intrathoracic pressure, converting the respiratory system from a negative inspiratory system to a positive inspiratory system causes decreased venous return and decreased cardiac output, to say the least. This is just a graphic representation of the air trapping that happen. And air trapping we can call it auto-PEEP, because if you have residual volume left in the lung and you deliver a second breath on top of it, the pressure at the end of expiration is not zero or not set pressure as CPAP. It's a little bit more. So the above points above the set rate or zero is going to called auto-PEEPing. And sometimes we allow auto-PEEPing, but we have to know about it. So you need to do a maneuver on the ventilator called expiratory hold, and that will let you know. This is just a graphic representation of air trapping, and another term for air trapping is auto-peeping, auto-peep. And basically what it means is that if you don't have enough expiratory time and the breath that comes on top of a previous breath that was not totally exhaled. So before full exhalation of the tidal volume you received in the previous breath, the second breath comes and stacks on top of each other, and hence your pressure rises. Now, auto peep is can be measured by asking the respiratory therapist to perform a maneuver called the expiratory hold, where the machine basically deliver a breath, let the patient exhale, and before the end of the exhalation, and when the second breath is supposed to come, the machine, instead of delivering the next breath, will just close both valves, inspiratory and expiratory, and keep measuring the circuit pressure. If there is more air returning from the patient still to the circuit, the pressure will rise, and that will be your auto peep. Here is another concept I told you for recruitment, which is inverse ratio ventilation. If you have a lung that is inhomogeneous, like ARDS lung, with areas that are consolidated and areas that are normal, if you push a volume, total volume, over a short period of time, it will preferentially go to the least resistance, and the least resistance will be the normal lung, and the diseased lung will continue to become not ventilated and dead space. So if you want to recruit those units, you have a better chance of doing so by delivering the tidal volume or the pressure over a longer period of time, where that will have a chance to open the stiff alveoli. But remember, when you inverse ratio, you decrease the E time, and when you decrease the E time, you end up with troubles of air trapping. So you have to monitor for auto peep. One other important point I would like you to notice here is that sometimes we apply either additional or more than a required PEEP, and that's also harmful to the patients. So if you're applying PEEP to patient with multiple units that are stiff, and then that PEEP will basically disseminate into the wall of the alveoli and not be transmitted to the capillaries. But if you apply a large amount of PEEP to normal healthy alveoli that over-distend them, what you do is actually you compress the capillary under them. And by doing so, you're diverting the blood from the alveoli that are working to the blood to the alveoli that are stiff, did not over-distend, and hence you're increasing your shunt. This happens in two situations. Either you are increasing the PEEP more than the patient require in the beginning, or when the patient is getting better. And this is a very important point. Sometimes you have patients who are in ARDS and are requiring a large amount of PEEP, say 15 or 20, and now they are on this for a few days and they are starting to get better. When they get better, you have more of normal alveoli. If you look at the x-ray, it's getting better. The gases are getting better, but then the following day, suddenly, the x-ray still look great, but the blood gases are worse, the hypoxia is worse. Now you wonder what's going on, and it's probably because now you have more recruitable units that are healthy, and you're over-distending and causing air trapping, or over-distending the alveoli. By over-distending the alveoli, you're increasing the shunt, and hence it's time for you to actually not increase PEEP, but actually to wean PEEP down and see if that would improve your hypoxia, because clinically the patient is doing better, then it must not need as much PEEP. What are the non-conventional ventilation? And they are not as non-conventional. Some of those we use now, but not as a first line, more likely as a second line. APRV, airway pressure release ventilation, high oscillation ventilation, and there's a subset of it called VDR, volumetric diffusive respiration. I'm going to touch on that. Jet ventilation is old, still being used sometimes. Liquid ventilation is experimental. Surfactant replacement, if we have deficiency in surfactant, we thought if we nebulize that, patients will lung get better. We've proven that over and over that it doesn't work. Nitric oxide is an inhaled nitric oxide, and it works by improving VQ matching. It's not good for adults because studies showed that it did not improve outcome and worsened renal failure. But it's still very widely used in pediatric population because it actually changes outcome. And then if all fails and you cannot use this lung to ventilate the patient, you might consider extracorporeal ventilation, especially veno-venous bypass that we have now. So APRV is an extreme form of inverse ratio ventilation. What does that mean? Remember when I said when you inverse ratio ventilation, now the inspiration is longer. It could be 1 to 1, 2 to 1, 3 to 1. APRV is an extreme where you have the higher pressures, which is conventionally thought as inspiration, for 4 seconds, for example, or 4.5 seconds. And then you let that patient pressure drop to baseline for half a second and then goes back up. The only critical point of this is that you have the patient P high, or the high pressure and inspiratory pressure, higher for a longer period of time and going down for a very short period of time. That means that they probably have air trapping, and hence they don't deflate all the way, so they recruit a lot more unit that way, and this unit stay recruited for a longer period of time. And at the same time, the machine allow the patient to take smaller breaths even during the high pressures and the low pressure. You can see those small blips on top in the inspiration and expiration. Basically, the patient is moving smaller tidal volume, 50 cc, 70 cc in and out during. So there is actually ventilation happening, not just when the pressure drops or when the pressure is released, but also during the high pressures and during the low pressures. That means you're also decreasing the excursion. Remember when we said the lung that is ventilated by 10 of PEEP and 45 of peak pressure was better than the lung that was ventilated by 0 and 45. And this is applied here because now you have the lung is expanded, and it doesn't really shrink all the way and come back expanded. So the shear forces on the lung is less, and hence less destruction of normal lung elements. Some people believe that APRV is more protective than all other forms, and some people actually use it as a conventional way of ventilating their patients, so this is their primary way. Now we don't use it here unless we have problem with recruitment and oxygenation. If the patient requiring high PEEP and if we considering going to inverse ratio ventilation, we just switch to APRV and we usually get very good results. Now, VDR, or volumetric diffusive respiration, is a combination mode. It's an ventilator invented by Dr. Bird, who actually is also a brand of ventilators. This ventilator was invented for military fields, and it's actually totally pneumatic. And what it does, it combines two things. Oscillation ventilation. Usually frequency of oscillation is between 400 and 600. At the same time, there is increased and decreased flows. No pressure, but increased and decreased flow. So you're oscillating flows. Say you're starting at a flow of 10 liters per minute, and then you're increasing that to 40 liters per minute and oscillating the same 60, and you're increasing that to 60 liters per minute for a period of time, and you're increasing the flows. Now, by increasing the flows, the oscillation produce increased pressures. This increased pressure could be on an open or a closed circuit, meaning that the endotracheal tube of patients who are on VDR doesn't have to be inflated, because it's basically flow oscillation. It's not requiring to increase pressures. But if you graphically write the circuit pressures, you can get the increased pressure. So basically, demand CPAP is the baseline oscillation at low flow, and then you increase that in inspiratory flow, and then you increase that convective rise, we call it, and it will go to accelerated equilibrium, we call it. So depending on the flow rate, from all the way 10 all the way to 60, 70 liters per minute, oscillating at 500 on average. And what is the importance of this mode? The importance of this mode is oscillation is very helpful in loosening secretion, breaking down bronchial debris, and that happened in inhalational injury. Patients who are on burn with inhalational injury, will benefit from that significantly. Also, because you are oscillating and it doesn't have to be a closed system, patient can tolerate higher pressures to so you can see here on that graph the convective rise can yield a pressure of 80 centimeter of water. If you come close to half of that on a conventional mechanical ventilation, patient will definitely get a pneumothorax. But in this mode, the patient tolerate that very well because it's oscillatory, and hence the pressure does not transmit directly to the alveoli all the way, causing barotrauma. This is just a picture of the ventilator. It's pure pneumatic ventilator. It does not have any electronics in it, so all you need is a pressurized gas source, and you can use it everywhere, anywhere. And the problem is, because if there is no electronics, is adjusting the knobs to get to the frequency, the convective rise, and so forth, the rates, and so forth, is going to be interactive. So when you change one knob, you might have to go back and adjust other knobs to get to the same character. So learning it is not that difficult. And there is no monitoring. I mean, you can see that monitor that you saw the graph of, but that doesn't tell you anything. It doesn't tell you what is a minute ventilation. Doesn't tell you. So all you do is you send a blood gas and follow on the results and adjust the vent accordingly, because monitors doesn't tell you exactly what's going on. I also want to touch quickly before I finish on NAVA, or neurally adjusted ventilatory assist. Now, remember when I said pressure support, measuring the differential flow between the expiratory and inspiratory limb, and that will be the trigger mechanism to tell the ventilator that the patient is breathing. Now, this is very adequate in adults because most adults who are ready to wean can create enough change in volume and flows for the machine to detect them, and they are breathing at a slower rate. But if you look at patients who are premature kids, say 500 grammars, who is breathing 40, 50 a minute, that's their normal rate, and their total volume is very small, 10 mLs, 8 mLs, 15 mLs. The machine is very hard to follow that fast rate at very small flow differences. So you cannot do it. So now we say, okay, electricity is fast, so why don't we put an esophageal probe? The esophageal probe will end up at the diaphragm. Every time the patient wants to breathe, the diaphragm gets a signal, and the electricity is very quickly transported with that sensor to the ventilator, and the ventilator will support the patient. So basically, neurally adjusted is following the diaphragmatic EMG signal and have the vent work with it. I'm not sure if this form of ventilation is advantageous in adults. I don't think there is any studies to prove that. It's definitely advantageous in pediatrics, and this is where most of its use is happening. I leave you with this quote, and now I see with eye serene the very pulse of the machine, a being breathing thoughtful breath, a traveler betwixt life and death. Thank you.